Hello, I'm Dr. Yusafit. Welcome to my YouTube channel. Today we will continue with the exit exam part 5 of your previous exams. So 27 years old man comes to the physician because of today's history of periurethral swelling. He was treated with oral cloxacillin for skin infection 3 weeks ago. His urine has turned darker. His temperature is 37.4, blood pressure 150 by 90, pulse is 18, respiration is 15 breaths per minute. Examination show periurethral swelling. Urinary show 8 red blood cell per high power field with RBC casts and mild proteinuria. Laboratory study shows low C3 level or complement 3 level. BUN is 40 milligram per deciliter. Serum creatinine is 2 milligram per deciliter. Which of the following is most likely diagnosis? A. Drug-induced acute interstitial nephritis. B. Acute pyelonephritis. C. Post-streptococcal glomerulonephritis. D. Membranoproliferative glomerulonephritis. Please pause your video and answer the question. So, in this particular question, they want to know this patient has glomerular disease, so they want to know whether the patient have which type of glomerular disease the patient have and their differential. So let's discuss about the glomerular disease. So are the most common cause of CKD and dialysis recurring renal failure. The most of those in developed world is diabetic nephropathy. Most glomerular diseases are also called glomerulonephritis or inflammation of the glomerulus, often as a result of an autoimmune event. So, like, for example, if autoimmune events like for example, SLE or systemic lupus erythematosus, which we call it when causing renal problem, we call it lupus nephritis. Lupus nephritis, so it is caused by autoimmune events and also circulating antibodies. For example, like post-streptococcal glomerulonephritis, as well as vasculitis causing glomerulonephritis are those with like Wegener granulomatosis and also eosinophilic granulomatosis and external purpura. Those are vasculitis causing vasculitis as well as glomerulonephritis. So red cells change shape, or dysmorphic or abnormal shape in some glomerular diseases. Other clue to glomerular disease are concurrent proteinuria with RBC casts, so which are pathognomic for the glomerulonephritis. So if you found RBC cast is only seen in glomerulonephritis. So if you found RBC casts, go for the differential causing nephritic syndrome. So please, for the cause of casts, I put a clear video with different casts and with their differential diagnosis. I put there with table. Please refer the exit exam part 1 for that, for different casts like WBC casts, RBC casts, or other casts as well. Based on presentation, it may be classified as follows. Glomerular disease, based on presentation, they are classified as nephritic as well as nephrotic syndrome. So in example of nephritic, like post-infectious glomerulonephritis, Goodpasture syndrome, and also for nephritic diabetic nephropathy, as well as minimal change disease, which is most commonly seen in children. So the great distinction between this nephritic and nephrotic syndrome is that having hematuria in nephritic syndrome and also heavy proteinuria in nephrotic syndrome. Heavy proteinuria means the nephrotic range is greater than 3.5 or 3 gram per gram of proteinuria within 24 hours. And most commonly the nephritic range nephritic syndrome have proteinuria is very mild proteinuria. Commonly it is less than 2.5 or is commonly less than 2.5 gram per 24 hour of procedure. So this is the other is in their great distinction is that in nephritic syndrome, the glomerulus injured through inflammatory reaction, but in nephritic the glomerular damage is not caused by inflammatory condition. So again, for both distinction, I put a very clear and again with their differential in part 1 of my exit exam video. So please refer that video for their difference. So I will put the link below. So post-infectious glomerulonephritis is a classic nephritic disease and with dark urine, hypertension, edema, and developing suddenly 1 to 2 weeks after strep pharyngitis. If not caused by beta hemolytic streptococci or Streptococcus pyogenes, it may be caused by throat or skin infection with Streptococcus pyogenes. So the post-infectious glomerulonephritis may be caused by throat or skin infection with Streptococcus pyogenes. Also rheumatic, please, this is very important slide, be focused. Also rheumatic fever only with the strain that causes strep pharyngitis. So in short, the strain that causes skin infection or impetigo and throat or pharyngitis can cause glomerulonephritis, but those strains that causes throat infection only can cause acute rheumatic fever. Again, the strain of this Streptococcus pyogenes, causing skin infection or impetigo, as well as pharyngitis, can cause glomerulonephritis. But when we come to acute rheumatic fever, those causing throat, the strain of Strep pyogenes causing throat infection only causes acute rheumatic fever, and those strains causes impetigo or skin infection doesn't causes acute rheumatic fever. So post-streptococcal glomerulonephritis usually follow streptococcal impetigo of M type, like 47, 49, 55, and 57. Throat infection with streptococcus 1, 2, 4, and 12 are also nephrogenic. So M type means the virulence, this most important virulence factor of streptococcus pyogenes. It is a surface antigen of streptococcus pyogenes, which prevents this M type is the virulence factor of streptococcus pyogenes. It prevents phagocytosis and others. The key to diagnosis is an association with infection. The post-streptococcal glomerulonephritis, the key is that association with infection. The best initial test is streptolysin or antihyaluronic acid. So this is the first best initial test. Complement level, particularly C3, are low, and renal biopsy is rarely needed, but if done, would show epithelial humps on electron microscope, and IgG and C3 will be deposited in the messenger. So for being C3 is low, that this in the pathogenesis of post-streptococcal or acute streptococcal or post-streptococcal glomerulonephritis, that it causes type 3 hypersensitivity reaction. So, for example, after throat infection or skin infection, one mechanism is that antibody to antigen complex will go and deposit in the glomerulus, and then they causes inflammatory reaction, and those will damage the glomerulus of the kidney. So during that inflammatory reaction, the alternative complement system will be activated, and the high consumption of C3. So they will go to the inflammatory area, and they will be low. The serum C3 level will be. So again, this C3 will deposit in the mesenchyme. So when you take the serum test for C3, it will be low. Treatment is supportive, and management of fluid overload and hypertension with diuretics is commonly, for most of the patient, it is enough. In most cases, resolve spontaneously. And antibiotic uh, in antibiotics, it doesn't prevent the post. By the way, giving antibiotics against this Streptococcus pyogenes uh, doesn't prevent the occurrence of the post-streptococcal glomerulonephritis, but it can just clear the throat infection. You can clear the microorganisms in the throat. Otherwise, it doesn't prevent. This is, by the way, a very important clue. They will ask you, the antibiotic doesn't clear or does it just clear the throat infection or the throat microorganism, but it doesn't prevent the occurrence of post-streptococcal glomerulonephritis. So there is glucocorticoid or steroids. Uh, Still, you will not give steroid for all patients with post-streptococcal glomerulonephritis. You will only give if if there is progressive renal failure, or especially in adults. So even the biopsy, by the way, biopsy is not important. Uh, and you will send for biopsy if there is progressive renal failure and if they resist for the treatment. Otherwise, it is enough to have those particular manifestation, and then unless it doesn't respond, or if the if the if the creatinine, for example, be doubled within 1 to 2 weeks, you may send for renal biopsy. This may be rapidly progressive glomerulonephritis, which may present as a nephrotic syndrome. So otherwise, renal biopsy is not important for diagnosis of post-streptococcus glomerulonephritis. So when you come to acute interstitial nephritis, it accounts for 10 to 50% of intrinsic AKI, and histopathology show robust interstitial inflammation with eosinophilia. This is very important. So, where is my so interstitial inflammation with eosinophilia. So the etiology usually adverse immunologic effect to medication, causing allergies in 70% of cases, including penicillin, cephalosporin. Those include like sulfa drug, allopurinol, rifampin, quinones. This allergic reaction can take a form of rash, Stevens-Johnson syndrome, hemolysis, and or acute interstitial nephritis. NSAIDs also can cause asymptomatic acute interstitial nephritis. That means lacking eosinophilia, and also having the NSAIDs also doesn't have severe allergic reaction. So treatment is iron. Treatment for acute interstitial nephritis should resolve spontaneously after stopping the offending agent. So, for example, if the sulfa drug or cephalosporin drug can cause those for example, if you do urinalysis and you found eosinophil, and also WBC castus, you may stop the patient's drug. So commonly, or almost in all patients, if you stop the drug that causes acute interstitial nephritis, they will the clinical symptom will resolve, as well as the renal problem will resolve. There is no specific therapy otherwise. If renal failure persists or worsen, consider short course of steroid. So short course of steroid. So back to our question. Back to our question. So this patient has definitely this patient had host streptococcus glomerulonephritis. This is the answer. So if you see drug-induced acute interstitial nephritis, we may see eosinophiluria in urine analysis. You should have to see eosinophiluria, as well as in acute interstitial nephritis, you will see WBC castus, by the way, not RBC castus. WBC castus instead of RBC castus. If we discuss that, if you found RBC cast, it is definitely this is glomerular disease, and it is in nephritic problem. So, and also the other very important clue is that if it is drug induced, we may see allergic reaction, especially rash in this patient. We may see rash or other allergic reactions feature. So this patient doesn't have any rash, and even cloxacillin is not the most common cause of drug-induced acute interstitial nephritis. And also, this skin manifestation is due to infection. Skin infection is not rash. So skin infection, it is impetigo. Definitely maybe impetigo. Just they want to know that this is impetigo. Or any form of skin infection, but the feature is not go for rash. So drug-induced acute interstitial nephritis is not the answer. So acute pyelonephritis. In acute pyelonephritis, the patient may have like dysuria, burning sensation during urination, dysuria, as well as frequency to urinate, as well as flank pain, bilateral or unilateral flank pain, as well as fever, nausea, vomiting. And also in labs, you may found in acute pyelonephritis, you will found WBC castus, not RBC castus. WBC castus, not RBC castus. It is just in the WBC castus, not RBC castus. So membranoproliferative glomerulonephritis, this is also this commonly causes nephrotic syndrome, nephrotic range of proteinuria, or it may cause nephritic range. It may cause nephritic syndrome as well, but this is commonly associated with hepatitis B and hepatitis C infection, as well as vasculitis. You may found vasculitic. You should have to found vasculitis rash on like purpura and other feature of vasculitis in order to diagnose membranoproliferative glomerulonephritis. So definitely this patient have post-streptococcal glomerulonephritis after 3 weeks of a skin infection. After 3 weeks of skin infection, which is impetigo. And this patient has hypertension, RBC castus, and also definitely this mild proteinuria, not heavy proteinuria, it is mild proteinuria, as well as AKI, acute kidney injury, which is seen with increased creatinine, which is greater than 1.2. So it is around 2 milligram per deciliter. This is more suggestive of kidney injury. So the patient have edema, which is periorbital, and also hypertension, RBC cast, hematuria, and also mild proteinuria with post infection of empty. So this is post-streptococcal glomerulonephritis. So next question, 26. A 16 years old girl comes to clinic with 2 days of burning sensation with voiding. She had sexual intercourse last week and her partner used a condom. The patient says, I always pee right after sex. She has no vaginal discharge. Her vital signs are normal. Examination so suprapubic tenderness. Urine analysis shows positive nitrates, positive leukocyte strains, and 15 white blood cells per high power film, and many bacteria. Urine HCG is negative. Which of the following is most likely cause of this patient's infection? A. Ascending infection. B. Hematogenous spread of infection. C. Sexually transmitted infection. D. Poor genital hygiene. Again, pause the video and answer the question. So let's go to discussion. So acute cystitis that occur after frequent vaginal intercourse is sometimes called honeymoon cystitis. So these infections are cystitis, by the way, mean it is just inflammation of the bladder. So inflammation of bladder. That inflammation may be caused by infection, maybe infection, or other cause can cause inflammation, but most common cause of cystitis or bladder inflammation is due to infection. So those infections are not acquired from sexual partner, but rather due to mechanical irritation associated with intercourse, or because during sex, the bacteria on your skin or around your rectum can easily introduce into urinary tract. So treatment is antibiotics 3 to 7 days. So that means it is ascending infection. It is not caused by, or you doesn't pass urinary tract infection to your partner. This is not sexually transmitted infection. So it is ascending infection. So back to our question. It is ascending infection. It is not hematogenous. Definitely this patient have dysuria and also frequency of urination after I always pee right after sex is more suggestive that this is associated with intercourse. Also for the STI, she has no vaginal discharge, no itching. So suprapubic tenderness suggestive of cystitis or bladder infection or inflammation. Positive nitritis as well as leukocyte strain suggestive of infection with commonly with gram negative, and many bacteria as well, which is suggestive of cystitis or urinary tract infection. So it is ascending infection. A hematogenous spread is not. This is commonly cystitis caused by, or urinary tract infection caused by hematogenous spread is for those patients who are elderly and also debilitating patient like diabetic and others. So for poor genital hygiene, they are not. The question doesn't tell the status of the patient. So this is definitely the ascending infection and read about honeymoon cystitis. So you will give antibiotics 3 to 7 days. It will resolve. The other, if you found such patients, it is recommended to tell the patient adequate fluid after sexual intercourse, that they will pass those infections through urine. 28 years old man comes to the emergency department complaining of fever, stiff neck, and photophobia. Which of the following is the best empiric treatment for this patient? A. Vancomycin, ceftriaxone, ampicillin, and dexamethasone. B. Vancomycin, ceftriaxone, and ampicillin. C. Vancomycin, ceftriaxone. D. Vancomycin, ceftriaxone, and dexamethasone. So definitely this patient had meningitis. Meningitis. So which empiric treatment do you give whenever you found meningitis, especially bacterial meningitis, acute bacterial meningitis? Which of those choices are given as empiric treatment for this patient? Answer the question. Let's go to discussion. Bacterial meningitis, an acute purulent infection of meninges, arachnoid and pyometer in subarachnoid space, can also involve the brain parenchymal vessels or vasculates in the parenchyma itself, or the tissue of the brain. Etiology depends on the age and risk factor. Common cause of community-acquired bacterial meningitis are the strep pneumonia, that account around 50%, Neisseria meningitis account 25%, Listeria monocytogenes 10%. Meningitis associated with mastocytitis, sinusitis, and otitis media. Also, aneurysms can play a role in such patients. So, this is your meninges. This is your meninges. This is the brain tissue. And this is the pyometer, which is very close to the brain. So meninges, in a short, is a coverage of this your brain tissue. So pyometer, then arachnoid, and the most outer part is, which is the toughest layer, is dura mater. So dura, arachnoid, and pyometer from outside to in. So age or condition and common bacterial pathogens. This is very important because you will treat with this scenario. You should treat, or the empiric treatment of your patient depend on this age as well as condition of the patient. So if it is age less than 3, the most common cause of meningitis is bacterial meningitis is E. coli group B streptococcus, which we call Streptococcus agalactiae, and shortly GPS, Listeria monocytogenes. Those are the most common etiology under 3 months. Infant and child, strep pneumonia, Neisseria meningitis, and Haemophilus influenza. Those adults less than 50 years and healthy and immunocompetent, you will give the most common cause are of bacterial meningitis are Streptococcus pneumonia and Neisseria meningitis. You will eliminate E. coli from this. So, if you found a patient who are immunocompetent and adults with less than 50 years, then you will give empiric treatment active against those 2 bacteria. It is enough. If it is adult greater than 15, Listeria monocytogenes come as a cause. So you will add antibiotic against this Listeria monocytogenes in addition to those 2 bacteria. So if the patient have risk factor like skull fracture or post-neurosurgery and develop meningitis, we should have to cover against those strep epidermidis, staph aureus, gram-negative negatives, streptopneumonia, and Haemophilus influenza. If he is immunocompromised, this all should be covered. Management is a medical emergency. Acute bacterial meningitis is a medical emergency. The initial management of the patient with suspected acute bacterial meningitis is empiric antibiotic or antimicrobial. And also adjunctive therapy. Adjunctive therapy with dexamethasone, either 20 minutes before first dose of antibiotic or within the first dose of antibiotic, with the first dose of antibiotic. Began immediately after obtaining blood culture and before the results are known. In short, you found a patient or you suspect a patient with acute bacterial meningitis, and then immediately draw blood. immediately draw blood and send to culture, then immediately don't expect the result to come. So immediately start empiric treatment with antibiotic plus dexamethasone. So empiric therapy of bacterial meningitis. So infant less than 1 month, ampicillin, cefotaxime, or aminoglycoside. So ampicillin, 1 up to 3 months, ampicillin, cefotaxime or ceftriaxone plus ampicillin or sure. And 3 months up to 50 years. Basically, our patient is in this age and he doesn't have any other condition. So ceftriaxone or cefotaxime plus vancomycin is enough to cover both. Which are the most common etiology in this age group? For those with immunocompetent, strep pneumonia, and Neisseria meningitis, and ceftriaxone or cefotaxime, or in short, ceftriaxone plus vancomycin is enough to cover these microorganisms. We don't need ampicillin because Listeria monocytogenes is not the common cause in this age group. So ceftriaxone or cefotaxime plus vancomycin is enough in those with 3 months up to 50 years who are immunocompetent. So you will add, if it's in old age of greater than 15 years, you will add ampicillin to cover Listeria monocytogenes. And also post-traumatic or post-surgery, you will add vancomycin, you will start ceftazidime to cover the organisms called Pseudomonas aeruginosa. With traumatic as well as neurosurgery, you should have suspect Pseudomonas aeruginosa as a cause of Neisseria meningitis. You should have to suspect in those with post-traumatic meningitis. As etiology, you should have to suspect Pseudomonas aeruginosa, and it will be covered with ceftazidime. So when we return to our patient, this patient age is 28 and just has no any other condition or risk factor. For example, the research doesn't tell us about trauma and like so. He's 28 years old, immunocompetent. So in addition to antibiotic, you will give adjuvant therapy. So our answer would be vancomycin, ceftriaxone to cover strep pneumonia and Neisseria meningitis, and also dexamethasone as a adjuvant therapy. So this is the answer. So let's see something. So please watch this one. So for our patient is in this range. You will start for 14 days. This means that you will send the culture already. You will send the culture of the CSF as well as the blood. If the result turn, you will update the result of after the result, you will update the antibiotic based on the culture of the time. If you found, for example, if the cause is Haemophilus influenza, if the culture is positive for Haemophilus influenza, you will treat with ceftriaxone, only with ceftriaxone for 7 days after the culture result. Even if you start with the vancomycin and ceftriaxone, you will then update the result after your antibiotic. You will update the antibiotic after the culture result. Don't miss that. So please subscribe. Please uh, subscribe. It's very important for me. Like and share for your friends. Thank you very much. And we will proceed to another video.